Great. Well, thanks so much. Thank you, PMD Alliance, for continuing to host us. It's been quite a ride here for the last several months, and we continue to be, unfortunately, physically distanced, but socially connecting. And I know getting into the holiday season, I start to feel some excitement. I was seeing some patients yesterday, and they were reminding me of the beauty of the holiday season with the fun sweater parties and the, Christmas trees and decorating and the yummy bakery items and eggnog and hot chocolate and things like that. But, it's also a time that I think we're missing our family the most. And so I think we want to make sure that we're realizing if that is affecting you and you're feeling lonely or isolated, to try to pick up the phone and maybe just make a phone call to somebody, see if they're also feeling the same way. And I think it's a nice way to try to keep the holiday traditions alive in some way, maybe to reach out, maybe send a card to somebody that, is across the world or across even the city that you are missing. I think social connection is so important. We've really missed that a lot in this year. And it's been fun to connect with you all. And I think this is my final program of the year, but we're going to be back, I think it's January 8th or something, with Ben Stetcher and his teaching us a little bit about his brain gym sort of ideas and different things that he's been doing as a young patient with Parkinson's in Toronto to keep healthy and fit. So that'll be some new year. And we'd also love to hear from you about if there are certain topics that you want covered, certain speakers that maybe you want to invite, on this program. Maybe just shoot Andrea an email and let us know, because we're definitely, wanting to keep this fresh and interesting and, relevant. So, let us know. And then it's with pleasure that I bring Nicole Herndon back. She was an amazingly popular speaker. She gave a talk on swallowing issues, and she's a tremendous part of the team there in the University of Florida. And we've had some great folks that are in that multidisciplinary team, ranging from their physical therapists. Mike Oken has been on, all the dietitian there, all kinds of folks. So I think, thanks, Mike, for letting us borrow some of your gang. And maybe Nicole, we can have you teach us a little bit again, just to maybe remind us briefly, because I know you spoke a little bit about this, and we can certainly refer our patients back to that great video, and we'll link it in the chat here that you gave. But maybe you can just tell us a little bit about, sort of where in the part of the country you grew up, and kind of, I think you had a family member that inspired you to become interested in taking care of swallow disorders and Parkinson's, if I recall. And then maybe tell us a little bit about how that team's fitting together, maybe in the COVID timeframe, because I know that we've had a lot of you folks that are separately on, but teach us a little bit about how that team works, and then we'll let you teach us.
Sure. All right, so my name is Nicole Herndon. I'm a speech pathologist in Gainesville, Florida at the UF Health Rehab Center at the Norman Fixell Institute for Neurological Diseases. It's a very, very long name, but it'll be on my slides in case you need it. So I work with a great team here of PT, OT, and another speech therapist. And you were talking about social communication and things like that. And obviously this is such a relevant time and obviously a relevant topic, talking about speech, but our day-to-day hasn't changed so much. We unfortunately haven't been able to set up telerehab. So we are seeing patients day to day. We're wearing our masks. I have mine right beside me. And we're still, meeting in between patients and sharing things about patients. We have a chat feature on Epic that we can use. So our day-to-day hasn't really changed, despite, patients having to wear masks and me having to evaluate their speech while they wear a mask. Obviously for the swallow, they have to take it down. We can't feed them through the mask. But we just have a great team. Obviously it's a multidisciplinary approach. So we kind of see the patient in the center, and all the disciplines revolve around the patient. So that's Dr. Oken was one of the co-founders of the clinic, and that was his idea, and a great idea it was. So going back to speech pathology and how I got into that. So I told the story last time, but my grandfather suffered a traumatic brain injury. He slipped and fell and hit his head. So that kind of opened up the door to me knowing what a speech therapist was. And then in high school, I was very fortunate that I went to a large high school in Indiana that allowed me to do an internship class and shadow speech pathologists. And I was a lucky one in that when I chose to go into college, I ended up getting a degree in that. So I didn't change my mind. And I've been working for over 5 years now. I've been at this center for over 2.5 years, almost 3 years now. And just the idea of how our center is run is what brought me here. So I'm very fortunate.
We're fortunate that that center exists as a model of really excellent care. And I love that patient-centered approach. I think that's so amazing. And we all wish that we had that, you know, and we could emulate you and clone you all and bring you out here, because you're just so gifted, and just really, you know, comes from the heart, I think, from just hearing how you talk about your patients and things like that. So we really appreciate that. So without further ado, I know that you, there were so many questions that came up last time because we were focusing on swallow, and people were asking some speech questions. So we thought we'd, you know, have a sort of you know, you come back round 2 and see if we could just focus on the speech aspects. Just to, you know, sort of plug in for the blog that Mike Oken, Dr. Oken, is on the Parkinson Secrets website. And he has a great blog, and I've been sort of sharing that spot. And Nicole wrote this amazing blog on swallow. We'll be having her do a follow-up one on speech, hopefully in the next 6 weeks or so. And definitely urge you to check that out, because I think it's a wealth of information. We're dispelling some myths, you know, trying to answer some frequently asked questions and things like that. Lori Ramig, who is the founder of one of the types of interventions that Nicole will talk to you about, actually wrote a blog for us this week. And so we'll, you know, you can look at that for more information, and then Nicole will be updating her side of things as well. It'll be great. Thank you so much. So I'll let you, without further ado, maybe I know you probably have prepared some slides, and we can kind of go through those on the speech side of things, and then we'll take some questions and discussion afterwards.
Okay. And while I'm pulling this up, definitely add questions into the chat feature, because I know you pull from that at the end, but I also think it helps me guide what sorts of things I might do on the blog. So it seems to be what interests people, what questions people have. So definitely feel free to jump in on that. So I'm going to share my screen. Okay. All right. Can everybody see that?
Yep, it's perfect.
Okay. All right. So obviously I'm going to be talking about Parkinson's and speech today. I know that that was the title on the webinar, but I'll also include a few things with some atypical Parkinsonisms. I know there was potentially a few of those individuals on the call today, so I just wanted to make sure I included them. So there's that long name of our center, the UF Health Rehab Center at the Norman Fixell Institute. We have this beautiful brand new building that we moved in about 1.5 years ago at this point. And we had kind of run out of space at our old center. We moved into this new center thinking we had tons and tons of space, and now our rehab side, we wish we could expand further. So there's just a nice little schematic there. Some of the topics I'm going to cover today, just some background in speech. So getting a little bit into anatomy and physiology, some reasons for or speech changes in PD, and some of the reasons why we tend to see that, as well as atypical Parkinsonism. And then really I want to spend a majority of my time talking about treatment approaches and strategies that can be used. And then I'll just do a quick concluding remark. So let's start off with speech. So it's the power of expressing or communicating thoughts by speaking or exchange of spoken words. So it's something that day to day we all use. And I want you, you know, the next time you are out and about, you're speaking with someone, think about the importance of speech. Think about what would happen, you know, if you weren't able to communicate, or think about if you're a caregiver, what maybe your loved one is going through when they have to spend so much mental and physical effort just to be understood by others. So taking their perspective a little bit. So I wanted to do a quick poll. I know Becky was going to help with this. So I just wanted to see who has received speech therapy. So the first one is yes, I've attended speech therapy sessions. Yes, only the speech eval, and no is you've never gone.
This is where we need the Jeopardy song, Nicole.
Yeah, I was going to say it's really a split here. So we have a split of, you know, not quite 50-50, but a lot who have attended and a lot who have never attended. So hopefully I can speak to those who have never attended, and then maybe I'll provide something new for those who have attended speech therapy, whether that was in the past or currently. All right, let me go to the next slide. Okay. So speech, it includes let me go back. It includes 4 subsystems. The first one being the respiratory system. So you use your lungs and your airway to push air out, and then it moves through your phonatory system, which is your voice box. On there you see it says vocal cords of the larynx. So your vocal cords are part of the larynx or your voice box. So the air moves through there, it gets your vocal folds vibrating. It gives it that vibratory motion. It goes up into the mouth for the articulatory subsystem. So using your tongue and your jaw to make different sounds. And then the resonatory system, so air moving through your nasal cavity. So certain sounds like N and M are going to have more of a nasal quality versus ones where the nasal cavity is blocked off and is more of an oral sound, could be like B or K, something like that. So there's just a little schematic there showing you the anatomy if you're not familiar with it. But all of these subsystems have to work together to coordinate these movements. So when we have discoordination, for example, when you have hyperkinetic movements like dyskinesia, it throws off your coordination. So sometimes these speech systems are impacted. So let's start off with speech changes in Parkinson's disease. So it can impact as many as nearly 90% of people with Parkinson's disease. And it kind of, we know that it's going to worsen as the disease progresses, but it's variable in terms of how severe it is, you know, the first 5 years versus the first 10 years for different individuals. And it's called a hypokinetic dysarthria. So that's the fancy term that speech pathologists will use. There's 6 different kinds of dysarthria, but for in Parkinson's disease, it's typically hypokinetic dysarthria. So what that includes is reduced breath support for speech. So we know, like I said, we need that respiratory system to send air through that voice box and turn on our sound. It can result in reduced volume, which is a kind of a hallmark feature of hypokinetic dysarthria, having that reduced volume. I'm sure many of you are aware that, or your caregivers have at least mentioned, you're speaking too softly, something like that. Hoarse or breathy vocal quality, and that can depend on a few factors. Short rushes of fast speech or faster speech overall. So sometimes I find patients, when they're speaking, it's the end of the sentences that speed up, and sometimes they lose clarity. And then at other times, it's just fast rate overall. Reduced clarity. More monotone, so less up and down inflection of your voice than maybe it used to have. Hypernasal resonance. And then occasionally people have stuttering. I've seen it where people have a new onset stuttering due to a neurogenic cause with Parkinson's disease. And then I've seen people who have stuttered as a child, and then it's kind of come back or worsened with the Parkinson's disease. So why do all of these changes happen, right? When people think Parkinson's disease, they see the motor movements, they see the tremor, the shuffling, things like that. But what causes these sorts of features that we see in Parkinson's disease? Well, it's the same things you see in the motor movement. So the hypokinesia, the reduced movement, and the rigidity. So we know that when someone is speaking faster, or maybe their speech isn't quite as clear, often I'll have someone tell me that they mumble, or someone's told them that they've mumbled. It's because you have reduced movements when you're talking here. And maybe when you're aware of it, you can get bigger movements, but then as you go on in conversation, we're going to get that hypokinesia leading to those changes. And then rigidity too, is particularly of the rib cage. So when you breathe in, you can feel some of that kind of resistance from the rigidity. Also, it can make some posture changes, which will impact breath support for speech as well. And I'm sure there's a mixture of that too within the articulators. There's ongoing research in this area, really trying to figure out more about it, but a lot also is looking at the neural connections that could create these changes. So articulation. So what this means is just how we produce the sound. So I mentioned the articulatory and the resonatory system, and these kind of go hand in hand for this section. So what we have found is that there's lower amplitude and velocity of movement. So there's that slowness to you can't quite get where you need to before you have to move on. And particularly at the lips and the jaw, there's also some research looking at that soft palate. Maybe we'll get a little bit of that extra nasal quality. We use a sentence that is make me a Hong Kong cookie. And sometimes we'll get some extra nasality in there that will be like, make me a Hong Kong cookie. So that nasal quality is kind of carried over. So let's try it really quick, because I'm sure most of you don't sit around all day thinking about how you produce speech, right? It kind of just happens. So try this for me. I want you to try and do an ah and then do an e sound and feel how your jaw moves. So the ah, your jaw should drop. It should be more open. And the e, it should lift to make the sound. You wouldn't be able to make the e sound without lifting your jaw. So now let's try it with the lips. So O versus E, your lips are going to be more rounded for the O, and then E, they'll have to pull back. And then same thing with sh and s. So I'm over exaggerating a little bit, but you can feel those difference in the movements for the lips. And then you can even feel what you do for B versus V. So B, you have both your lips touch, whereas V, you take your teeth and you bite your bottom lip, and you have some vibration there. So just bringing that awareness to what the jaw and the lips kind of do for speech. And then a thing that I like to focus on a lot is speech breathing. So while you're sitting here just breathing, your breathing kinds of just have an equal inhale and exhale. So it's a nice kind of sine wave and up and down. But when you breathe in for speech, you're going to have a quicker, deep inhale and then a longer exhale. So it's not going to be quite as even between the inhale and the exhale. And so what research has found is that in those with Parkinson's disease, the breathing varies a lot more than age-matched controls. So maybe, one sentence you have nice loudness, you don't run out of air, and then the next one, your breath pattern changes and you're squeezing out the air at the very end. And then I know this gets a little messy, I'll explain it. So relying more on abdominal breathing to change the lung volume and smaller rib cage volume initiation. So overall, you're using less expansion of your rib cage to try and get air in and out for speech and squeezing your abdominal muscles more. So for those without Parkinson's, the tendency for breath is to breathe in and then exhale, and you're going to hit this kind of certain point. So you breathe in and you exhale to this certain point. But research in Parkinson's shows that inhale is less, and then you go below this certain point by engaging your abdominal muscles. So you're squeezing the air out. So you're taking advantage of less of the recoil of the lung. So I brought a rubber band in. So lung recoils when you breathe out, your rib cage and your lungs stretch, and then they recoil back to a certain point. So it's never going to come completely back. So if you breathe in really, really deeply, you're going to have to engage some extra muscles so that your lungs don't just go. But we want to make sure that what we're doing is that we're expanding that rib cage and coming back, and not just barely expanding it and then using our abdominal muscles to squeeze it out, because it's less effective and it uses more effort because you're having to engage those abdominal muscles. We'll play around with it a little bit more at the end. And then another thing that I often hear is I'll have a patient come in and say, I'll ask them, what changes have you noticed to your speech? And they'll say, well, she says that, my volume's lower, but I think it's her hearing. So we're getting kind of the blame game here. Someone thinks it's someone's hearing, someone thinks it's their reduced volume, but we do know that in Parkinson's, lower volume is a key feature with that hypokinetic dysarthria. So we know that there's a mismatch. I'll also have patients tell me, I feel like I'm speaking plenty loud, and then when someone can't hear me, I say it louder, but I feel like I'm shouting at them, even though they say that I'm not. So it's just a harder time to regulate the volume and knowing what is an appropriate volume. So those sorts of things change over time. And the idea is that, your breathing and your volume changes so slowly that your brain adapts to it. So thinking about this calibration, your new volume is what your brain says is your normal volume, but it actually has just changed over time. So I just wanted to quickly cover some speech changes in atypical Parkinsonism in case anybody's on here. So I have some additional dysarthria types just on the side for reference in case anybody really wants to get into that. But so PSP can also have some hypokinetic features, which is the dysarthria type we'll pretty much focus on today. But they can also have some other variations as well, including spastic, like a strained vocal quality that's a little slower. And then they have a speech and language variant that can have some apraxia of speech. MSA, multiple system atrophy, it kind of depends on the subtype. So MSAP, Parkinsonism, is going to be more of a hypokinetic, it'll be more severe earlier on compared to Parkinson's. And an MSAC, cerebellar, is going to have some ataxia, just some ataxic dysarthria, the slowing, the imprecision. That's different imprecision than what we see in Parkinson's disease with the hypokinesia. Dementia with Lewy body and cortical basal degeneration also have some hypokinetic dysarthria, not always, but it's something that we look for. And then the cortical basal degeneration, particularly if it's cortical basal syndrome, can have apraxia of speech. So I briefly wanted to highlight speech and medication and speech and DBS, because I know that's something that people say, well, you know, the meds help or reportedly help with motor movements. What about speech? Well, it's inconclusive. I have patients clinically that tell me, oh, you know, once I started medication, my speech improved. And then I have others that say that there's no impact, and all of that goes along with the research. It's a non-motor symptom. Same thing with DBS, really. So it's speech is less responsive than the global motor limb dysfunction. And then between STN and GPI, which are common targets for Parkinson's disease, there's variable results. So it seems to be on a case-by-case basis right now. And STN maybe seems to be a little worse for speech, but ultimately we don't expect changes with deep brain stimulation. Some of the changes that research has found are thought to be due to lesion-like effects or stimulation-induced effects. So it's just something that if you do undergo DBS or you do have DBS and you feel like you have speech changes, just let your team know. They can try some programming settings and see if they can give you some relief. So, but it's not really common to see speech changes. All right, so let's get into treatment. So there's 3 different sorts of categories I'm going to cover today. So remediation, compensatory, and communication strategies. And for those who are caregivers or family members of those with Parkinson's disease, the communication strategies are going to be very helpful for you, hopefully. So the first one I'm going to focus on is LSVT loud. So that was, I have that blog post, the Parkinson's Secrets blog post listed there that Dr. Subramanian was mentioning. And this is a well-researched treatment approach. It's a very intensive speech program that's 4 one-hour sessions a week for 4 weeks, and it's on a one-to-one basis. And the research has shown that it increased loudness, intonation, so that's that inflection in speech, improves vocal quality, and also improves clarity, as well as decreases speaking rate. And it includes home exercises for carryover. We want to make sure that you're not just improving in the speech room and you don't carry that home. And then maintenance exercises for continued benefits. So I would say the one thing that I've noticed about this is I have had patients complete this program and they don't continue on with the maintenance exercises. And we know that Parkinson's is progressive. So you have to keep up the maintenance exercises to maintain the benefits. So that's really important when I have a patient saying, should I do the program? Shouldn't I, you know, I think if they would benefit from it, I want them to continue the exercises. So Speak Out is another program. So they focus more on speak with intent, whereas LSVT loud is think loud, speak loud sort of idea. So Speak Out is a newer program. It's starting to have some research behind it. And it's about 12 therapy sessions that's spread out over time. So it's less intensive than the LSVT loud program. And it's been shown to increase loudness and improve perception of voice function. And this program also includes some cognitive exercises in it. So I've had some patients do the program and really like that it covers that as well. Once again, it includes home exercises for carryover and then those maintenance exercises for that continued benefit. And then once you complete the program, there's a group therapy called Loud Crowd that you would be a part of. I think typically it's weekly sessions, and that will just help you with those maintenance exercises. Oops. All right. Another one is Speech Vive. So this is a wearable speech device that kind of fits almost like a hearing aid, and it includes multi-talker babble to elicit the lumbar effect. So the lumbar reflex is when you are in a louder environment, your loudness goes up. So that's kind of what they're using. It's this, it's kind of like if you go to a restaurant and you blurred what everyone was saying, but you could still have that sound effect in your ear. That's kind of what it sounds like. And the research has shown that it increases loudness, length of utterance, clarity, and intonation, or that inflection. There's a picture of the device there. And then there's a picture of a lady who is wearing that device. So it's less of a training program to really remediate your speech, but there's been research that if you take it off, you do have some continued benefits. And it's something that just got covered a few months ago, I think, as a durable medical equipment. So more and more insurance is covering it. I know the VA, there's multiple VAs across the country that cover it, and then some individual insurances. Another one is my friend, the EMST, expiratory muscle strength training. So there's some preliminary evidence that it helps with speech breathing. So I just have an example of 2 of those devices there. I also spoke about these in terms of cough and swallow function in my last talk as well. Other options could be a voice amplifier. So I listed 3 here. Most of these I think you can get on Amazon. Really, you can get anything that would amplify your voice. Sometimes a more portable system or the portable speaker could be helpful. But just know that this is something that you're going to use just to kind of compensate. So it's not going to be something that really improves your speech. It's just so that the other person can really hear you more clearly. And another one is AAC, augmentative alternative communication. So this is rarely needed in Parkinson's disease from the patients that I see, but I wanted to just cover it. So there's low and high tech options of these speech generating devices that if you have difficulty speaking, it will be an alternative form to communicate, or if there's a lot of difficulty understanding you, you can augment your communication. It kind of, some of them look almost like an iPad or a Windows Surface Pro idea, and they have different language systems on them. So let's focus on some communication strategies. And I know that oftentimes the person with Parkinson's disease is the one that kind of takes the blame for more of the communication breakdowns. But there was a great talk on the Parkinson's Foundation website. It's one of their past expert briefings. I linked it here, that talks about the reasons for the breakdown, and also includes that other people may speak over the person with Parkinson's, or the conversation moves too fast before the person with Parkinson's disease can jump in. So it gives some ideas for how to improve communication that way, particularly in the group settings, because we know that communication involves a listener and a speaker. So we want to make sure that we cover both of those. So what are some speaker strategies? Well, face-to-face, and then reducing background noise and distraction. So this is going to be for both partners in that communication, the speaker and the listener. And it can be really important. I know right now with the masks, we're all experiencing what it's like not to be able to see someone's face and fill in the gaps for helping with our understanding of what they're saying. Getting the attention of your listener prior to speaking. So I always give the example that when you are in a group setting, maybe point out one person in the group. You can say, hey, Susie, get Susie to look at you and start to say what you want to say, so that they, can pull the rest of the group in, or get you the attention of your spouse in another room, so that you're not finished saying what you want to say and they say, were you talking to me? What did you say? And then you have to repeat it all over again. So get their attention first. Once you have some verification that they're listening, then tell them what you want to say. Provide context. So this is a good communication repair strategy. So if someone isn't understanding what you are saying, say, I was talking about dinner. What do you want tonight for dinner? Something like that. So that they have context and they can fill in some of the information that they're not getting. So fill in the information the listener didn't hear. So you can say, well, what did you hear? And then just fill in what they didn't hear, but also make sure that what they're hearing is correct. So you want to make sure that you don't end up with a cheeseburger when you wanted a taco sort of thing. And a common set of strategies that I use, we call SLOP strategies. It's not the nicest name, but I'll explain what that is. So S stands for slow, L stands for loud, O stands for over articulation, and P stands for pausing for more frequent breaths. So I'll go into a few of those now. So to slow down and to improve clarity, I really like the strategy of over articulation. So we talked about the hypokinesia, so the reduced movement. So here we want to overdo it. So I tell my patients, I still want you to have your natural rhythm. I don't want you to sound robotic, but I want you to focus on precision and movement of each syllable. So I have that little visual there. You can see the smaller movement. And then as you're practicing it, I want you, sometimes being in front of a mirror can be helpful to over articulate what you're saying. And like I said, it helps improve clarity, helps you to slow down. So I have a lot of patients who know that they're going too fast, but don't know how to slow down, because when they think slow down, that doesn't work. So instead I'll tell them over articulate, think about bigger movements, and sometimes that's helpful to them. So the next one is being louder and breath support to get louder. So here's a nice visual of your inhale and exhale for speech. So I kind of did it with my hand earlier. So you have that sharper, deeper inhale, and then as you're speaking, that should be the exhale. So I tell my patients, take a deeper breath at the beginning of each sentence. And like I said, be a little bit more dramatic, because we know if you're underdoing it and you practice overdoing it, it's going to end up meeting somewhere in the middle. And that's going to help loudness. It's also going to help maintain loudness so that you don't, towards the end of the sentence, just kind of fade in your volume. And it can help improve vocal quality. So sometimes that hoarse vocal quality comes from not having enough air moving through your voice box. So sometimes I'll have people try and take a deeper breath and say a sentence and see if it helps. So let's do a few sentences. I'll pull a few from my therapy that sometimes I'll use. So let's breathe in and say, today was a beautiful day. So inhale, and then on the exhale, say that sentence. And then try maybe a longer sentence, like, please put the groceries in the refrigerator. Something like that. So making sure that that volume doesn't fade as you're talking, making sure I put that straight line, it's maintaining, and then making sure that we're using our air. We're not breathing in, holding our breath and talking while holding it, and then releasing it afterwards, nor are we breathing in, exhaling air, and still talking on empty. So really pay attention to your breath. It's a really, really crucial point for speech. So what are some listener strategies? Once again, face-to-face, reducing background noise and distractions. Getting attention of listener prior to speaking, but really this should be, I think I carried that over on the wrong one, but letting the listener know what you did or did not hear. So say, I heard you wanted something for dinner. What was that? So then they're not having to fill in all of it. You're just having them fill in what you didn't hear in the first place. And that's going to help with fatigue. Sometimes it helps with frustration, because what you don't want is someone saying, oh, never mind. You know, it's not important anyway, something like that. Give the speaker time to respond. So if you say something and they don't hear you, give them time. Sometimes dual tasking, they're doing something else, and they'll get to you in a second. Maybe they didn't hear you, but if you give them time to respond, they'll have maybe better breath support for speech. Maybe they'll be able to answer you before you repeat it again, something like that. So once again, trying to reduce frustration. So just to conclude, I just wanted to put this in here that I always recommend a formal speech evaluation by speech language pathologists. It's important to get a baseline, so see where you are, and then at least an annual reevaluation. We'll see our patients typically every 6 to 12 months, so we can follow them, track some changes, and then give them home therapy, home exercises, or outpatient therapy, something like that, if we feel like it's warranted. And we just want to make sure therapy is individualized. So just because you have Parkinson's disease doesn't mean every Parkinson's disease patient should get the same speech therapy. Our jobs as speech pathologists are to make sure that what the person's diagnosis is matches what we're hearing, but also the speech presentation is different. So sometimes the vocal quality is more impaired compared to something else. And so, you know, our ear, we're trying to figure out what's going on. So I definitely do think seeing a speech therapist can be helpful once you get your diagnosis, and then continuing on. There's my references. Thank you for having me again. This is always a pleasure. So I wanted to open up the floor for any questions.
That was awesome. So organized and so clear. Really awesome talk here. So we have a ton of questions. I'll try to sort through them. Some are a little bit more specific that we might not be able to cover, and some are specifically around atypical Parkinsonism, which may not be terribly relevant to the whole group. And so we'll maybe leave those to sort of later on. But one question is, with hearing aids, you hear yourself as louder than others may hear you. How do you deal with that issue? So I guess there's some sense that, you know, you because you have these hearing aids and may not know what your own voice sort of sounds like. Do you have any sort of information?
Yeah, so I think it goes along too with that calibration. So I've had patients say that obviously your mouth is closer to your ear than the other person that you're speaking with. But I will say the tendency is that volume may still be reduced, but I tell people to focus on your effort behind it. So your perception has changed, but how much effort do you need for someone sitting 2 feet away from you versus someone who's in another room? And that would definitely be something that a speech therapist could help you with, because we can change the environment, we can change the background noise. So we can add components so that you can start to figure out what's helpful. Another thing that I like to use in therapy is a dBSPL meter, or there's apps on your phone that you can get. I like the Decibel X meter, but there's many out there. And you can put it about 1 to 2 feet away from your mouth. It's gonna pick up differently the further away that it is. And shoot for around 65 to 70 dBSPL is what I tell my patients, decibels for sound pressure level. And that can give you a good judge of conversational loudness. And sometimes too, you can record yourself. All of us, you know, have phones or something that can record our voice, and you can play it back and listen to see if you fade further on in the conversation, maybe if you fade at the end of a sentence. So using some of those feedback tools can maybe help you figure out better what's going on with your speech.
Okay, great. Somebody asked here if you've run into people who've had impaired speech from Duopa pump.
From a Duopa pump, I haven't, and I don't think it probably connects to it. Maybe what's going on, I know the Duopa pump could maybe give maybe some dyskinesias. I've seen that. So with the dyskinesias, you're going to have a hyperkinetic dysarthria. So it's going to be more of that coordination. Sometimes you'll get a strained vocal quality because you don't coordinate a good breath in. So I guess that's hard to answer without knowing more how their speech presentation presents, to see what's going on behind that.
Yeah. And I would say just from my view, I think, you know, the pump is not anywhere near anything that produces speech. So it's really going to be sort of a side effect possibly of too much or too little medication, just like medicines can affect speech. But whereas with deep brain surgery, some of the electrodes are placed in areas, if you stimulate them, you know, sometimes it can actually, as a side effect of the stimulation, the speech centers can get affected depending on where the locations are. And so I think that sort of makes more sense that DBS or deep brain surgery stimulators may affect speech, but I wouldn't expect Duopa to directly affect speech.
Yeah, I agree.
And then how do you choose, you know, you had mentioned a couple of the different types of speech therapies, the LSVT, as well as Speak Out. And somebody here, Reverie, writes that Speak Out has helped her tremendously. And she does maintenance with a friend.
Yeah.
So I think, it sounds like, how would you kind of get a sense of that? I mean, I know that it looks like LSVT is quite intense. You need, an hour each day for 4 days. And then the maintenance is also pretty intense. Is it sort of like has to do with your ability to commit to the therapy, or are they the same intensity of commitment? What's your sense of that?
Yeah, so they both have similar concepts behind it. LSVT Loud has a bit more research, but it's definitely, we were talking about this earlier, it's been kind of developed from the 1980s, whereas Speak Out was developed in 2010 by the Parkinson Voice Project. And LSVT Loud is Dr. Ramig. So I think it's difficult to figure out one versus the other. I like to present both options and allow the patient and whoever is going to have to be driving them to those appointments kind of figure it out. LSVT Loud, you have to do the 4 1-hour sessions a week for 4 weeks. That is, to call it LSVT Loud, that's what you have to do, whereas Speak Out has a little bit more flexibility in it. And I really enjoy the individual saying that she does her maintenance exercises, she's found good benefit, and she's maintained that benefit, hopefully. So it really is important. I think it's about 10 to 15 minutes per day of the maintenance exercises. So I think, at the end of the day, I think it's what would match best for that individual and their circumstances. And then if someone really wants the research backing it, LSVT Loud is going to be that choice, but Speak Out is coming out with more and more research. They're only 10 years old, so which in the research world is very young.
Sure. And is there a sense that is one more available than the other, like across the world, or are both pretty available at this point?
Yeah, so LSVT Loud, when I was on their website recently, said that they had about 10,000 clinicians, whereas Speak Out has about 2,500. Speak Out is so both you have to kind of get your certification in. On the LSVT Loud site, you can see who's certified. Speak Out provides some grant funding for speech pathologists to get that. So, and I think both programs are probably across the world, but because they're both developed in the US, I imagine they're a bit more popular here. But I have found if you're trying to find where providers might be, the LSVT Loud website, I think it says find clinician on the right side. You can put international ones in there. I found one for someone in Australia before. And then I think Speak Out has that option as well. I don't know internationally, but I haven't used that, but you can always contact the program and see.
That sounds good. And are they able to be done through a telehealth mechanism at this point?
So LSVT Loud it's called eLoud. It's something that they actually had prior to COVID. So with telehealth, it's for speech pathology, different states have different restrictions, but typically you have to have a speech therapist that is in your same state or has their state license. In that state, Speak Out is doing a lot right now with COVID. They have videos posted on their Facebook page. And I think it's supposed to be for those who have completed the program, but they record them and post them. So anybody who's done the program and is wanting to, get back into those maintenance exercises because I mentioned it, or just wants a change of getting into them, or if you can't do it with your friend anymore, they have some posted there. And I think LSVT Loud at one point was doing some videos as well, but not the actual program. Speak Out has more flexibility, I think, so it would be SLP specific and how they provided that therapy.
That sounds good. There's a question about the cognitive exercises. Could you teach us a little bit about what those are? The cognitive exercises, I think you mentioned that the Speak Out had some cognitive exercises.
Yeah, so I'm not exactly sure, 100% sure what's included in it, but I do know that they try and do naming items, in categories or something like that. So I saw that on their website. So I'm not sure if anybody else can speak to what sorts of things. It comes in a booklet for the patients to have with them. But it's really, we know that cognition can change. And we know that it does change in Parkinson's disease. So I really like that component, even if you're not having difficulties maintaining that function. And it doesn't hurt to work out your brain. I tell people all the time, just like you work out your body, you got to work out the brain. So anytime you can incorporate cog, I know I didn't cover it today, but I love incorporating speech tasks while dual tasking too. So doing the PT exercise and counting out loud using your good breath, motor and cognitive, naming items in a category while you're doing a PT exercise, using your good deep breath, anything that you can do to use more of your time, but also make it harder if you're safe.
Sounds really good. So there's also some questions about, the concept of the speech Vive. You're using it in one ear, and you show the picture of the person who's talking on the phone and had it in the other ear, the one ear. So it's one ear that you wear it in, is that right? Yep. And then they're asking, can you use it with, can it work with hearing aids? And then also there was a question about, is there a way to, use it with the sort of like a way to kind of, a cheap way of doing it would be to maybe put like one earbud in with playing some sort of background something, sort of, would that work as well? In like if you were to put your earbud in with your phone, maybe like some background music or something.
So SpeechVive is in one ear. You can wear it if you wear hearing aids, but you couldn't have that hearing aid in at the same time. So there's a certain time of day that you train with the SpeechVive. So maybe that's when you wouldn't have that hearing aid, and it would go in your less severe ear. And it's something that SpeechVive, the company and the SLP you're working with, would be able to figure out if it works for you. Before you order it, since it is durable medical equipment, you have to show that someone would benefit from it. So you have to see a clinician that is able to test it out to make sure that you would get benefit from it. So I think that's a great thing before you spend money to get something. I was fortunate, so Jessica Huber is the one who developed it, and I was fortunate that I did some research with her, and I was in her lab for it because she's at Purdue University, so boil her up. So reach out to our company. They would be able to answer kind of those nuanced questions like that. It's going to be different than just putting music in your ear, because the reason why they don't have some of that noise, they don't want it to be perceivable speech, is because that can be a bit distracting. So their thought is that if you can put a device in your ear, it's less mental effort to get that increased loudness, and it doesn't take a big training effect. That's kind of their perspective there. So I can't speak to just putting something in your ear. I think it would cause maybe some of the lumbar effect, but we also want to make sure someone's not going to injure their hearing by doing that. So, yeah.
There's a few other questions here. So people are asking about, so there's something about, for someone who has been in assisted living lockdown for 9 months with no speech therapy since then, what are chances of speech improving now that he's no longer there and still no access to help because of the shutdown? As his mother, I can't understand his mumbling. Do you have any thoughts about that?
Yeah, so there's things that you can do at home. Reading aloud is a great task. What I like about that is you can see the words, there, so you can apply your strategy without that added level of having to formulate a sentence, find your words, things like that. Singing is also great, humming even if you're not a singer. Like I mentioned, counting, any sort of practice. So practicing things that you say often. So we call it functional words, phrases, and sentences. So how are you? How is your day? I want this for dinner. What time will you be home? I have to go to the bathroom. Have you seen my glasses? Those sorts of things that you say again and again, practice it with your strategy, whether that's breath support or trying to improve clarity with over articulation, whatever your strategies are. But we know with neuroplasticity that the best, if you don't use it, you lose it. So we got to make sure that you're speaking. And I always want people to be speaking effectively, but efficiently. So trying to apply those strategies that maybe I mentioned to some of those exercises. So it can all be done at home. So.
Yeah, I mean, I think that's great. And I think, it's some of these programs are quite expensive, if insurance doesn't cover it, or I think there's a lot of people who are hungry for things that might just have some videos that they can try. to get a taste of things and see if they can commit to it maybe before they sign up for one of these bigger programs. Any links that you might have, Nicole, we'd really appreciate it, because I think, just having a sense of what's out there. There's also a question here about a person who lives alone. Are there devices or ways to monitor what their voice is doing? They don't have awareness of what they sound like from day to day, because I guess they're not practicing talking. So is there a way to monitor that, or do you have other thoughts on how somebody maybe who lives alone may be able to practice talking maybe with others? Maybe, I don't know if you have similar patients.
Yeah, so I do have many patients who, live alone, or they'll tell me, I don't talk much during the day, and their spouse will say, sit there and agree. So think about something that can provide some feedback to you. So you can record yourself and play it back and see how you think you sound. You can also, like I mentioned, that DB SPL meter app. Like I said, I use the Decibel X sometimes in therapy, but there's many out there. You can download it to your phone, your iPad. Just make sure that when you're using it, it's at a pretty consistent distance to your mouth. Otherwise, it's going to pick up differently. And obviously, the further away, the higher the target volume. So I typically tell my patients about 2 feet away, trying to shoot for about 70 dB SPL, but knowing that, it's going to fluctuate up and down and things like that as you're speaking, because we have those ups and downs in speech.
So there's another question here about if you live alone, how much should you practice?
So I say daily, but also take those moments. If you pick up the phone and you have a phone call, take that moment to use your breath or to use your strategies for your speech. I would say 10 to 15 minutes per day, but you can find, minutes here and there. You could be describing a task that you're doing. We're all washing our hands a ton right now, right? So, describing each step, that using your speech out loud, maybe I'm in Florida, it's kind of cold here, but warmer than other places, but maybe you're watering your garden, or maybe you're talking about turning up the heat or calling to get your heat fixed, something like that. So just talking out loud as much as you can. Remember, if you don't use it, you kind of lose it, that sort of strategy. So whenever you can. And I have patients say, well, I don't want my neighbors to think that I'm crazy, anything like that. I'm like, well, they talk to other people. They don't often know that you're alone. So don't worry about it.
Or you could talk at them through the rose bushes or something.
There you go.
I wrote Get Payback with those telemarketers. That's right. You can sort of ask them to describe their product and keep talking to them. That's funny.
Perfect. I like it.
There's been a question about maybe some singing and how that might affect breath and voice and sing stuff.
Yeah, so I like singing for breath support because you have to take breaths at a certain point and maintain good breath support, so your vocal quality stays steady so that you can make it through without running out of air. We have a group here called PD Sing for Life. There's many other options across the country of singing groups, whether you want it specifically for Parkinson's disease or if you just want to join it. I have patients who are in their church choir. So I really like singing. There's some research out there too about singing and its benefits to speech. I just didn't pull that today. But once again, going back to you're using your voice, you're focusing on your breath. I think that's always a good thing.
Absolutely. Yeah. And I think people have linked some Orange County Trumbull Clefs and some other folks. And we would refer you back to Matt Brodsky had talked about singing or music and the brain and Parkinson's. And so definitely refer you back to that. And somebody's asking if there's a maintenance songbook. So I'm not sure if there's actually, is there a known, and then somebody's written about park singers with Angela Gabriel in Santa Fe. So it looks like there's all kinds of folks that like to sing out there. Is there a singing book that's specific for helping voice that you know of, or?
No, I think anything. I think find something that you enjoy and then sing along with it. Just make sure that you're not straining your voice, anything like that. If you feel any vocal fatigue, give yourself a little bit of rest, but.
Yeah. And then I think also, just sometimes, I have patients that come in, they don't put their teeth, if they wear dentures, things like that. Are there other tips just in general, just even outside the Parkinson's and sort of populations that you can kind of recommend just in general to make it as easy as possible for somebody to be articulate?
Yeah, so that's going to probably be more in precision. Is that what you've noticed? It's just not as clear.
It's just that they don't have their teeth in, sometimes it's harder for us to understand. Sometimes people come in and they have gum in their mouth. You know, there's just, I think, you know, sometimes, you know, I think with the swallow issues, making sure that people have cleaned their mouth out and then swallowed sometimes, you know, if they're in a meal and they're trying to talk, it's sometimes just a lot of things happening. And I think one of the questions here was about possible aspiration while trying to swallow and talk, you know, these sort of multitasking.
Yeah.
And I think, you know, if you could comment on that, maybe that would be helpful.
Yeah, I mean, I've heard it too with the excess saliva. I know that's a common thing, or someone's chewing gum because they're trying to prevent the excess saliva. So our mouth adapts. So if you've ever had braces or retainer or any dental work done, you know, the first few hours, it's definitely not clear. And then you kind of adapt from there. The strategy that's probably going to be most effective is focusing on precision. I think when someone doesn't have their dentures in, their tongue is a little bit less precise in the movement. So maybe trying to focus on precision of each syllable. For the excess saliva, I like more frequent sips of water to clear it out, you know, taking that break while talking, swallowing, finishing your swallow, and then going back to talking. Chewing gum can sometimes be helpful, sugarless gum, sugarless lozenges. So yeah. Not too many options if you don't have teeth, but.
So there's some people who wanted some clarification on like some of the devices and also the acronym. I think we're running out of time, so we would have people probably watch this again. And then there's some questions also on swallow. And I think we would urge people, and we can link your other talk because it was amazing. But this hour has just literally flown by. It's like so much to say. And there's Music Men's Mind was also mentioned here as another singing group, and Tremble Clefs of Arizona, or trembleclefsarizona.org. So like there's like about 6 music groups that we've had some inspiration. Maybe people are singing some Christmas and Hanukkah carols at this point. Tremble Clefs. It's like, yeah, lots and lots of stuff. So definitely maybe we can link some of these, some of the singing groups. And I think it's a great way to socially connect as well. Thank you. You're just such a joy to have on here, Nicole. And it's just so awesome to have had the inspiration from your granddad. And then I didn't know the story about how you did the shadowing in high school. What a great thing that you were inspired to do and you got a chance to do it. And here you are many years later, still loving the area. That's just so inspirational. So maybe as sort of before we say goodbye, you could just give our gang out here a little bit of hope, maybe a final tip or two from your perspective as we kind of welcome everyone to the new year and, you know, the holiday season and stuff like that. And thanks again for spending the time with us.
Yeah, thanks for having me. So just wanted to wish everyone a happy holidays. I know it's a bit different this year. A lot of people are doing Zoom or FaceTime, something like that. So just know you can always incorporate your speech strategies, but any speaking during the day is good. So just make sure you try and incorporate the strategies to prevent those communication breakdowns. But you know, you can't be thinking about it all the time. So take those little moments here and there. If you remember your strategy, take that as a win, set little goals for yourself, and that's going to make the bigger change over time. So
that's awesome. Well, thank you again, Nicole. Happy holidays to you and yours. And Andrea, I'm going to pass it back to you. But first, I want to wish everyone a great holiday season. Stay safe, stay connected, and we'll look forward to seeing you all back here in January.
Yes, and let's show our gratitude for Nicole and Dr. Subramanian with a goodbye wave. And I feel like we've become friends over all of these sessions. Phil, I love your sign and your light up. So just sending holiday wishes amongst each other too. So to our speakers, but also amongst each other in this community. So thank you, everyone. Have a great afternoon.
Thank you. Bye-bye.
I like Michael's red nose there. That's very cute too. Cute just to flip through the gallery view. I love that.
Yeah.
Hi, guys.
Bye-bye.